This is The Rounds Table. Welcome back, listeners. This is a new format, new style of episode, and it will be discussing trial files. What is trial files? It's a newsletter generated by a large language model, free to receive, and direct to your inbox twice a month. Most relevant for the general internist or maybe budding general internist. One is a throwback edition, which summarizes trials from years gone by, and the other summarizes recent practice-changing trials. So in the most recent edition, it was a throwback trial files. And what were the three articles included? Well, first up was effect of opioid versus non-opioid medications on pain-related function in patients with chronic back pain or hip or knee osteoarthritis, aka the SPACE trial. It was published in JAMA in 2018. In brief, it was a pragmatic, 1-year-long randomized trial that evaluated the long-term outcomes of opioid versus non-opioid medications in patients with moderate to severe chronic back pain or hip or knee osteoarthritis. They randomized 240 patients, and the intervention arm would involve some form of opioids like immediate release morphine, oxycodone, maybe hydrocodone, and acetaminophen, and the comparator were non-opioids, often NSAIDs, or it could have been acetaminophen. The primary outcome I really liked. It is what patients care about, which is their pain-related function, measured using a validated tool called the Brief Pain Inventory. This score ranges from 0 to 10, and higher score indicates worse function. So over the 1 year, what did they find? Well, the score in the opioid group was 3.4, and in the non-opioid group, 3.3. So difference of 0.1, not statistically significant, not clinically significant either. But adverse medication-related symptoms were significantly higher in the opioid group. So this just feels and continues to feel like such a relevant clinical trial for so many of the patients that we care for, either in hospital or in an outpatient, family medicine or general medical clinic. And I actually didn't even realize this trial existed until very, very recently. So maybe this is useful information to you as well. And just some really good data to show that Tylenol, NSAIDs, is going to give as good of pain control compared to opioids, but with lower adverse events. Okay, 1 down, 2 to go. Next up, the effects of IV albumin on renal impairment and mortality in patients with cirrhosis and spontaneous bacterial peritonitis, published in the New England Journal of Medicine in 1999. That is a real throwback. So we included this article because I was recently on service and we were looking after a patient with SBP and we ordered albumin, and I wondered, I actually don't know what the trial was to support this. I know it works. I know we should be doing it, but I didn't actually know the underlying data, hence why this has been included. So, the bottom line that this was a randomized trial that involved 126 patients with cirrhosis and SBP, and it was assessing the efficacy of an antibiotic plus intravenous albumin versus an antibiotic alone. The antibiotic in question was cefotaxime. I'm not sure how often that's used these days. I have never used it. The primary outcome was renal impairment, defined as a non-reversible deterioration of renal function during hospitalization. So, using creatinine. And what they found was that 6 patients in the intervention group, or 10%, experienced renal impairment, compared to 21 patients, or 33%, in the comparator group. So, boom goes the dynamite. That's an absolute improvement by 22%. Additionally, 22% of patients in the intervention group died at 3 months, compared to 41% in the comparator group. So, potentially a lower risk of mortality. So overall, the study concluded that intravenous albumin, in addition to antibiotics, reduces renal impairment and mortality in this patient population. And that, my friends, is why we give IV albumin in addition to antibiotics for patients with SBP. There have been a few other clinical trials in this space, which I'm not going to go into, but overall found similar findings. And there's been more than one meta-analysis that has been published showing that, hey, IV albumin, it sure does work in this scenario, hence why it's standard of care. All right, 2 down, and what is the last one? The last one is, what is the effect of omeprazole before endoscopy in patients with GI bleeding? This was published in the New England Journal of Medicine in April 2017. This one was included because almost every time that I'm attending on the general medical ward, we admit a patient with an upper GI bleed, and almost always we start them on IV PPI. But it's been a while since I've actually looked at the data to support that decision, realizing that it must be the right decision. That's what we do. But what did the data actually show? So this was a randomized trial, and it looked at the effects of preemptive infusion of high-dose omeprazole on the need for endoscopic therapy in patients with upper GI bleeding. There's a total of 638 patients who were enrolled and randomized to omeprazole or placebo. The primary outcome was the need for endoscopic treatment, and it occurred in 19% in the omeprazole group compared to 28% in the placebo group. So that's like a 9% absolute risk reduction. In terms of safety outcomes, no difference in transfusion rates, and the rates of transfusions were 1.5 versus 1.9 units, which, to be honest, that kind of surprised me. I would have assumed that PPIs would reduce the need for blood transfusion. They also looked at the outcome of recurrent bleeding. No difference on that. Emergency surgery, no difference on that, but emergency surgery in this scenario is so rare. And they also looked at 30-day mortality, which actually showed no difference, but there weren't that many events. On endoscopy, fewer patients in the omeprazole group had an actively bleeding ulcer at 12 of 190 some odd patients compared to 28 of 190 some odd patients in the placebo group. So overall, this study concluded that omeprazole infusion effectively reduced the need for endoscopic intervention and accelerated the resolution of signs of bleeding in ulcers. But again, it didn't actually reduce the need for a blood transfusion. So that's it. Hopefully short and relatively sweet. Just a quick recap. What have we talked about? We started with a study published in JAMA in 2018, the SPACE trial, which showed for patients with knee, back, or hip OA that acetaminophen or NSAIDs are just as good as opioids, but have a low risk of adverse events. We then discussed the effect of IV albumin for patients with SBP, and a reminder that it led to lower mortality as well as lower renal impairment. And then we ended with, why do we give IV PPIs for patients with GI bleeding? And the study in question showed that it reduced the need for endoscopic intervention and accelerated the resolution of signs of bleeding and ulcers. I hope you found that helpful. Let us know if you like the new format, hate the new format. If you're not already, sign up for trial files, let your friends know about it. We're trying to increase the spread and scope of it. It's been a fun sort of pet project to work on. And yeah, this is just also a nice opportunity to give a shout out to the many team members that are part of the core trial files team. So Katerina Zorchich, Emily Barch, Brian Lim, Genevieve McCallum, Tamara Van Bakel, Allison Hacker, as well as most recently Danielle Cutler. I hope you enjoy this. Have a great day and take care.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.